Hi everyone, I want to talk to you about neonatal resuscitation. It's conan to neonates, and that is the age of 1 to 28 days. So, what do we expect? In other words, what is going to happen there in the delivery room? Neonatal resuscitation. Let's go. Most babies are normal at delivery, but you just need to get ready for the very few. About 10% of them will require assistance. Depending on the center, depending on the protocol, and depending on the availability of the trained personnel, delivery rooms are filled with neonatologists, midwives, anesthesiologists, and other skilled people in neonatal resuscitation. Like I've said, it's all depending on the center, the protocol, and the availability of these trained individuals. Okay, get ready. Get ready for what? For neonatal resuscitation. And get ready with what? Okay, get ready with transport incubator, radiant warmer, warm towels, cardiac monitor, oropharyngeal airways, laryngoscope with straight blades, number 0 for preterm, and number 1 for term babies. Get the oxygen ready and make sure it is flowing. How about the meconium aspirator, particularly if the history is indicative here. And nasogastric tube, 8 French, 10 to 20 cc range, mechanical suction, tubing, and catheters. Have your face mask ready. You might need D10 intravenously here. Get that prepared. Naloxone, 0.4 milligram per ml, particularly with the history of narcotics or opioids in this woman. In the mother. Epinephrine ready. Syringes and needles. Make sure they work in. Gloves, umbilical catheter, 3-way stopcock, antiseptic, plastic wrap with probably scalpel because you are going to pass through likely umbilical vessels. Okay, you have all your stuff ready. It is not in all cases, like we said, it's only 10% of them that will require this help. But how then do you get prepared for all this without any prior history? So you anticipate resuscitation if you think, oh, with the history of this pregnancy, this is going to be a premature delivery. So you know the gestational age. This is less than 36 weeks. Okay? Maybe this is between 32, 33, 34, thereabout. So you get ready. This is a postdated delivery, greater than 41, 42 weeks already. Get ready. Intrauterine growth restriction, that diagnosis has been made. Ultrasound has been taken before. The size of the uterus, everything like that, with the history in the mother, the type of sickness in the mother, anemia, hypertension, and name it. Big baby is a woman with gestational diabetes mellitus. You are anticipating a big baby to be the product, or the woman is physically big and your ultrasound is showing that the baby is also big inside, or this is a multiple gestation, 2, 3, triplets, quadruple, and so on and so forth. Breech presentation, because there's going to be a lot of stress while taking the delivery. So you expect that the outcome will be a baby that would have been stressed out. So might not be able to cry, might not be able to initiate the first breath. Chorioamnionitis as infection, and the baby might have aspirated and coming down with sepsis, going to septic shock, and so on and so forth. Instrumental delivery. You've used your vacuum or forceps, and now you're anticipating that the outcome might not be too good right now, so you get ready. And of course, cesarean section, because baby who pass through the birth canal and they will pass through a lot of squeezing, flexing, and so on, and that will help the lungs to become effective immediately they are delivered. But baby delivered through cesarean section, they've avoided that passage, and they are more prone to respiratory distress because they have not passed through the birth canal, so they might need more assistance. Narcotics before birth, and that's why we get our naloxone ready, because it has both cardio and respiratory depressive effects on both the mother and the child. The reason why many doctors will not give narcotics close to the time that the woman will be asked to push and the baby will be brought out. So you give it at the early onset of the labor, not few hours to possible delivery. We still continue to anticipate when the amniotic fluid is stained with meconium. Then we know this child is passing through stress in utero. So we'll be anticipating meconium aspiration syndrome. And of course, if this woman had had premature rupture of membrane, we know there's possibility of infection. With premature rupture of membrane, that's why it is contraindicated to use digital examination. You don't put the glove on and use your hand to be checking the dilatation of the cervix all the time in a woman with premature rupture of membrane. If not, you're going to introduce infection and the baby coming will be infected. And with that, you're going to anticipate possible resuscitation in this child. And like I've alluded to just a while ago, gestational diabetes mother will have baby with big size and possible birth defect, possible traumatic defect, birth problems as well, because they might be delivered through assisted delivery with forceps and all the likes, and even most of them with cesarean section because of cephalopelvic disproportion. So we anticipate resuscitation in them, and of course they come down with severe hypoglycemia because while in utero they've been supplied with glucose, high level of it for that matter, and with that the beta cells of the pancreas has been stimulated, and when it's been stimulated, more insulin is released. Insulin is an anabolic steroid, so it helps in growth, and that's why the baby is massive, very big. And when this cord is cut off, immediately the glucose supply is cut off. And when the glucose supply is cut off, insulin level is not suddenly cut off. So the insulin is still working and the glucose is not there. So with hypoglycemia, they become tired, they become flaccid, so we need to help them. And the baby of a mother with preeclampsia or eclampsia, the high level of blood pressure could have led to possible insufficient supply to the baby. And even in a prostrated baby with placenta insufficiency, it's all the same. So we prepare for them. Bleeding during pregnancy or placenta previa means less supply to the baby, and bleeding disorders in the mother. A mother who has been smoking, on drugs, on alcohol, and had a separate presentation of fetal alcohol spectrum disorder. I have not made any presentation on smoking in pregnancy, and I'll look to find time to get that done. Extremes of age in the mother, too young or too old, anticipate resuscitation in the baby. Lung disease, heart disease, or kidney disease in the mother, or poor socioeconomic status might give a clue that the child had not gotten good supply while in utero. So while coming to life right now, what is this child going to live on? The child who has not stored enough glycogen will come down with hypoglycemia immediately after birth. So with all this in mind, you get yourself ready. So the history, the obstetrical history, the history of this very pregnancy, the history of resuscitation in previous deliveries will all be clues to how we need to get ready. Resuscitation starts from when? From antenatal. Set the goal with the mother or the two parents about possible outcome of the resuscitation given the problem on ground. For example, if you have known that this is going to be low birth weight baby or intrauterine growth restriction, or you know that this is a woman who has a particular type of problem, then open up to the parents, to the father, potential father, and the mother that for this reason, we are likely going to have trouble when the child is delivered. But we're going to get this type of people, these highly skilled people on ground to help. However, I cannot definitively say that the outcome will be this or the other way. I agree on non-resuscitation if they choose to, or I agree to both follow the procedure. I agree on trying your best, but not sure of the outcome. So there's no reason to raise their hope, and the hope is dashed later on. The steps to embark upon. Do we need to resuscitate at all? How are we going to make that determination? What is the ABGA score? Is it good? And have we checked the equipment? Is the team notified about the pregnancy history and preparedness? The baby has arrived with good ABGA scores. Great. We are not going to resuscitate here. Let the baby stay with the mother, provide warmth. In fact, bring the baby close to the chest of the mother. Well, that was a slip of the tongue. You can bring the mother close to the baby, just bring them close to each other. Provide warmth, begin normal care. Clear any secretions from all the orifices, check from head down to toe again, and make sure the baby is in order. All right. Not time baby. ABGA score, not so good. Sorry to hear that. Then we need to get a warmer, clear the secretions, dry the baby, and try to stimulate that baby to cry. If this baby is apneic or gasping and the heart rate is less than 100 per minute, we need positive pressure ventilation. We're going to monitor oxygen saturation here. I'm going to hook up the EKG. The baby is not gasping, but cyanotic and dyspneic. We clear the airway. Guide the oxygen saturation level. CPAP, give oxygen. If heart rate is less than 100 beats per minute, then we're going to assess the chest movement, intubate if necessary, and laryngeal mask if required. If heart rate is greater than 100 beats per minute, we are going to begin post-resuscitation care. We are going to carry the entire team along, but if heart rate is less than 60 beats per minute, please intubate. Do chest compressions, positive pressure ventilation with 100% oxygen. Let the EKG monitor be on, and emergency umbilical venous catheterization. We're going to check the heart rate again. If it's still less than 60 beats per minute, then we're going to give our intravenous epinephrine. We're going to look out for the cause of this bradycardia. Is it hypovolemia? Treat appropriately with appropriate infusion. Is this pneumothorax? Decompress. Targeted preductal oxygen saturation after birth are the first 1 minute, it should be 65% and thereabout. And that should increase gradually to 70 at second minute, 75 at third minute, and 80 at 4 minutes. By the time it's 10 minutes, it should be about 95%. Okay, we have done the resuscitation, we've done our best. Congratulations, the child is fine or not. Okay, post-resuscitation, you are going to check out for post-resuscitation complications. Hyperthermia from excessive warming or hypothermia for inadequate of the same. Hypoglycemia by taking the blood glucose, and the hypoglycemia might not actually be a problem, but because of many reasons, including gestational diabetes mellitus in the mother, and the child has been subjected to high level of insulin without commensurate supply of glucose post-delivery, or hypoglycemia because we spend a lot of time resuscitating without feeding, and there's not enough glycogen stored in this baby because he or she has been having intrauterine growth restriction before now. Is there any hypotension here? Maybe we need to put over fluid, electrolyte anomalies, speed from laboratory work, decreased functioning, or decreased sucking reflex, GIT bleeding, paralytic eye loss because of hypokalemia, or too much mechanical touching of the intestinal wall, or there's pneumonia, transient tachypnea of the newborn, pulmonary hypertension, and the central nervous system presented with apnea, seizures, and aposic ischemic encephalopathy. Are we going to withhold resuscitation? The main issue is to have a meaningful dialogue with the parents, and please jointly take that decision together. That will afford you the opportunity of letting the parents know exactly what you are doing and why you are doing it, and why you think now is the best time to stop because of the possible outcomes that you are going to get. And that will also afford the parents to know that you've done your best, and then you are off the hook of any legal implications. And even ethically, that's excellent. Let the parents be involved in that decision. When can we discontinue resuscitation? After you spend 10 minutes of effective efforts with your entire team and everybody had put in the best, we are going to discuss with the parents about the prognostic findings. And the prognosis could be that the child may likely die. Sorry to hear that. There's no parent, after suffering for months to carry the pregnancy, even both the mother and the father will want to hear that. We should express some level of empathy here. Or high morbidity after this resuscitation. In other words, if we continue with this resuscitation and the baby is handed over to you and you go home, later on in life, the baby can become this and this and that, and you may not be happy with that. Again, this is not what they want to hear, but then that is being honest on your part. Make sure that the parents have agreed before you discontinue. In other words, there's no fixed time, but after you've done the best, you've done everything for good 10 minutes, you can have that dialogue, but you have not stopped. The team leader is making that conversation with the parents while the rest members of the team are still working on the child. So they agree, or there should be no disagreement. The two groups, the parents and the healthcare providers, must come to an agreement on discontinuation. There was a case that happened that came on the TV in America a few years back, that they had to get the legal expert, the lawyers got in, the DA, everybody, it was on the news, people were monitoring it. The doctors were saying we're done, the family said you're not done, and they couldn't stop it, and everything continued. They were moving from one end to the other. So I could understand with the family. I'm a father. It's painful to hear that. And my heart goes to all parents who have been faced with this decision. It's painful. But then, decision must be gently made. In conclusion, within your power, do all you can to save that baby. But never do it alone. Carry the parents along. I'm truly wishing all those little ones well. Thank you for listening to my presentation. Kindly subscribe so that you can get these presentations immediately they are published. Thank you.